Hi, I'm Ann Kim, a senior editor at Washington Monthly, and today I'm speaking with Merrill Goozner, a former editor of Modern Healthcare and author of the newsletter Goose News right here on Substack. Hey, Merrill.
Hi, Anne. Thanks for having me on this morning.
Yeah, thanks for coming on. You have written an article for the monthly titled For Democrats, a New Way to Make Healthcare Affordable. Now, most of the attention on healthcare right now has focused on the extension of premium subsidies for people who get their coverage through the Affordable Care Act, Obamacare. But your piece argues that this debate misses an even bigger crisis that affects the majority of Americans who get coverage from their employers. So, can you talk a little bit about the depth and breadth of this kind of hidden crisis?
Sure. 165 million people get their insurance through their employers, they and their family members. This is half the United States population. When you think about Obamacare, very important. Those are for people who don't have plans through their employers or are independently, work independently. But that's only about 24 million people coming, through this year who have joined Obamacare. Very important, patching a big hole in the insurance net. But when you think about the larger picture, the same price increases that we've been seeing on Obamacare plans that are driving their rates higher, we're also seeing in employer based plans. And in employer based plans, the individual, usually in almost all cases, in fact, pays out of their paycheck either every week, every 2 weeks, maybe every month, about 25% of the cost of the plan on average. Well, when plans are up around $27,000 a year for a family plan, 25% of that is a very large number. Then when you add on top of that, that's growing at 6% to 7% a year. That's what's projected for next year. What we're going to see is people having a large part of a significant part, let me put it that way, of their increase in pay, which is generally 2 or 3%, every year, going to pay simply for the higher premiums. And this is before the higher copays and deductibles. So it's not exactly hidden to the people who are experiencing it, yet it's been hidden in our political dialogue this year as we head into 2026. People are going to be seeing this in the next couple of weeks. That's why I wrote this piece for Washington Monthly that says, hey, we really need to come up with a plan that deals with the overall affordability crisis in healthcare. And that's, of course, what the article that appeared a couple of weeks ago or last week in Washington Monthly was all about.
Mhm. Yeah, it's definitely not something that's getting very much attention right now. And the other thing that's interesting about your piece is that, a large part of the debate has actually been about paying for the premiums, premium subsidies. But you're actually talking about bringing down costs, the underlying forces that are causing premiums to go up and people needing some more help. And your piece offers three specific ideas for tackling the healthcare affordability crisis at its roots, which is rising costs. And I want to walk through each of these three ideas very briefly. So the first idea you propose is an 8% cap on out-of-pocket expenses, meaning that no household should pay more than 8% of their annual income on healthcare overall. Can you give a little more details about what that would look like for households?
Sure. Well, first, let's get into the rationale for why a cap is necessary. Right now, you can end up paying 9, 10, 11% of your income. And if you get extremely sick, hold amounts of your income just to be able to afford the copays and deductibles that are within each plan. We burden the sick when they have very high costs with that. Over time, this has led to a significant share of our population actually accumulating medical debt. The numbers are like 20, 30 million people are paying off credit card bills, are putting aside other bills in order to, keep making payments on their debt. So I thought the most important thing we can do is to provide immediate relief to all families, no matter what kind of plan you're in. And I even include Medicare and Medicaid in this idea because don't forget, care people also pay out of pocket. A lot of the lower income people who are on Social Security, who are seniors, must pay a Part B premium out of their Social Security check, which is your doctor care. and then you have, if you end up in the hospital and you can't afford a supplemental plan, and that's about 10% of the people on Social Security, you end up paying that first $1,000 or $1,500. I forget what the exact amount is right now, but of that
Mhm.
hospital visit, a lot of people simply can't afford that. And so they're experiencing Medicare debt, excuse me, medical debt. And so I thought the first important thing to do is a great reform would be, let's just cap everybody's plan. This will require payers, we call them payers in the healthcare wonk space, but we're talking about private insurance companies. We're talking about Medicare. We're even talking about Medicaid. There are some Medicaid programs where the very poor have to make some small payments out of pocket. So you just apply it to everybody and you say nobody should ever pay more than a set percentage of their annual income in any given year for all healthcare expenses, including their taxes, which would be if you're a worker, your Medicare payroll tax. And it would also include, if you're a senior citizen, your Part B and Part D premiums. So we just say whatever it is that you're paying for healthcare, up to a certain percentage. This would be very progressive because people who make $200,000 a year or $300,000 a year, that's 8%. And I use that as an example. The exact
Mhm.
percentage could be, you could say negotiated or determined what it ought to be. It's one I think that is more or less an average, that I thought might be logical, but that could be examined what exactly it needs to be. But whatever it is, somebody who is making a lot of money will have to pay more out of pocket, but it never would go over 8% than compared to somebody who was maybe making 30, 40, or $50,000 a year. So it is a very
Mhm.
progressive way of approaching the whole question of what people are paying out of pocket, which of course is the very definition of the medical expense crisis that people are facing.
Yeah. This does sound like it could cost a little bit of extra money, and we'll get to that. But first, I want to walk through the other two ideas that you have for actually reducing costs. Presumably, those out-of-pocket expenses would also be lowered as a result too. And one of the second idea you propose, one of the other ideas, is a single pricing system where hospitals and doctors all charge the same amount for a particular service. I mean, say right now you get an appendectomy, so Medicare would pay one price for that procedure. Let's just say $15,000 to pick a random number. Medicaid might pay only 10, and then you got private insurers who might end up paying 20. But what you're proposing is that everyone gets charged the same. All payer rate setting, I think is one way to describe it. What are the benefits of that regime and how would that bring down costs?
Yes, let me just underline a few of the things that you just said, because it's very important to understand that we have the most convoluted and confusing pricing system in the world. And all of our insurers and our providers must administer this system. Why do I say it's convoluted and complicated? It's because it has a price for Medicare, which is set by the federal government. It has prices for Medicaid, which are set by the private insurers. People don't know this, but about three-quarters of all people on Medicaid actually have their plans managed by private insurers today, just like half the
Goodness.
Medicare patients have their plans administered by private insurers. That's the Medicaid Advantage program. They have separate prices and different plans, even within these government programs, can have different negotiated prices. And then you have the private insurance market that covers employers. Employers either self insure using an insurance company as what's called a third party administrator, or they buy a policy, in essence, where the insurance company evaluates their risk as an employee, a group of employees, and says, this is what your insurance policy is going to cost. So now imagine this. You might have three or four. Sometimes there's one or two that are dominant, and that's a separate question. But still, there might be three or four or five insurance, or sometimes as many as a dozen insurance companies operating in a market, each of which can negotiate its own rate. Imagine now if you're a doctor or a hospital's office, you have a billing department that is billing Medicare one price, billing Medicaid another price. These are lower than the private insurance market.
Mhm.
The private insurance market, on average, according to an ongoing RAND survey, is about 2.5 times Medicare prices on average. And then you have the private insurance market where you can have as many as a dozen rates. Imagine trying to say, okay, the code for this colonoscopy, say, if you're going in for that, is, I forget I don't know what the codes are, but it has a number, a series of letters and numbers. But my price attached to that code, I might have 8 or 9 or 10 prices. Imagine trying to administer such a system. And it's the same thing on the
Expensive.
insurance side. It's extremely costly. A single pricing system would generate tremendous savings in administrative costs for the healthcare system, hundreds of billions of dollars a year. And this could pay for a lot of the reduced pricing that you would have on the employer side, as well as the increased pricing that you would have on the public payer side. Medicare under single pricing, let's be completely honest about this, the government prices are going to come up somewhat, and the private insurers are going to come down to a single price. Okay. So there is a shift from the employer side to the public payer side. Now, the question becomes, how do you capture that? Savings is some of that. We just outlined that. But then, of course, what you need to do is increase the tax on, or some kinds of taxes, in order to raise the money to have single pricing. Now, don't forget,
Mhm.
if I'm an employer and I am paying 2.5 times the rate of Medicare, and Medicare is coming up somewhat, and I'm coming down so that we all pay the same price, I'm going to be saving an awful lot of money on my overall premium. This reduces the 25% that my employees pay out of their own pocket for that insurance plan. And it reduces me, the employer, because I'm covering 75% of the cost of that plan. So they're going to get a big break. So when we say we have to increase, and I'm putting scare quotes around the
Uh-huh.
increase word, excuse me, but they're going to be getting a break on the actual cost side. And so, how that shakes out on whether they're going to be paying more or less will really depend on the risk pool of the employer. How many sick people they have, what their overall insurance costs are. And depending on how you structure the tax, perhaps depending on how profitable they are. So as I point out in the article, single pricing is in effect a form of industrial policy, because one of the things the Trump administration talks about this all the time, it's trying to do is it's trying to bring back manufacturing to the United States, a worthy goal, something I've written about since I was a beginning reporter in the 1980s here in the industrial Midwest. I live in Chicago. I've been doing this for a lot of years. And the thing that employers even then used to complain about is that when we compete with the Japanese or we compete with the Germans, we start with $1,000 a car disadvantage because of what we're paying for health insurance. Okay.
Mm.
These
Mhm.
guys have a national system in which they have much lower costs. And so this would benefit them on the business side. It also would have an equity or a progressive approach to health insurance as a whole, because in the industrial sector, as I said, I live here in the industrial Midwest. When you go out to General Motors or Ford or Caterpillar, John Deere, they have factories here. They're still making machinery, but their workers tend to be 45, 50, 55 years old. They are getting closer to being older, old age, and getting onto Medicare. They have more healthcare problems. General Motors and those kinds of companies pay a lot for their health insurance per family, per worker.
Mhm.
Now take Apple or Google or Meta. And these companies, they have a workforce. The average age might be 35. It might be 40. They're younger, they're healthier. So their average cost when they create a pool for those workers is less. So if we move to equalizing the pricing, and then charging in some fashion employers to capture the money, not to make them pay more than they're paying now, but as a
Mhm.
group to pay the same at least, and you determine what tax level that needs to be and what tax you need to get it, you have the real potential of creating a fairer system among employers where everybody is picking up their fair share of the total employer cost. Now, this is all contingent on the idea that we want to maintain an employer based system. Employers say this all the time. Workers in unions say this. They often administer their own funds. Let's not forget about the fact that there are these called Taft Hartley funds where they are doing, providing health insurance for their members. These tend to be multi employer, like in the construction industry or in other industries that are highly fragmented by firm, and they are still unionized. Clothing industry was a classic example of this. We don't have much clothing manufactured in this country, but they
Mhm.
also administered their own anymore, but they also administered their own funds. All of these groups want to maintain their own employer-based system. Okay. And don't forget, this was a huge attack on, Obamacare, on the law. They said, oh, they're going to take away what you have. Well,
Yeah.
by equalizing it, by single pricing, by making the tax system more fair to recapture the money that employers are paying in a fairer way, we allow them to keep what they have. So I think it's politically attractive. I think it's good industrial. It's a good policy for promoting the return of manufacturing and maintaining what manufacturing we have in this country. And it will create a much more simplified system for the healthcare system that will save literally hundreds of billions of dollars in administrative costs every year.
Terrific. Well, just to recap here, you've proposed number one, an out of pocket expense cap for all households. Number two, single pricing for all services provided by payors, hospitals, doctors, etc. So let's talk about the third and final piece of your plan, which is a so called global budget, meaning that hospitals will be paid a set amount every year for all of the services they provide versus getting paid by service, which encourages a lot of unnecessary procedures. And you do point out in your piece that the state of Maryland actually already has a variation of this system. What have been the outcomes there, and why is it a good model for the rest of the country, especially in tandem with the single
Yeah.
pricing system that you
Yes.
propose?
So let's begin talking about the fact, global budgets are necessary because the United States, Americans pay the highest prices in aggregate, even with equal pricing. We will still be paying on a per capita basis more for healthcare than any country in the world. And many years ago, a very famous, now departed healthcare economist by the name of Uwe Reinhardt, who was German, he moved to the
Mhm.
United States, became an American. Everybody said probably the best healthcare economist in the US. And he wrote a very famous article. He helped co-wrote it. It's the price is stupid. Why do we spend
Yeah.
so much? It's because our prices are so high. Now you can tackle that problem in a number of ways. One is through antitrust and trying to make sure that there's more competition, and not that that's a bad idea, but that will take a long time to work through the system. The other way, of course, is through controlling prices through some type of regulation. Maryland had a single pricing system going all the way back to the 1970s. They never got rid of it. Other states had it and they got rid of it. And in Maryland, however, they kept it. But what they discovered, and this really sort of manifested itself, or
Mhm.
over in this century, is that, well, if you have single pricing, you can still, it's like the old story, you make it up with volume, right?
Yeah.
So it drove volumes higher, and people were actually encouraging, they only put it on the hospital systems, and so it encouraged hospital systems to begin subcontracting out or even buying up ambulatory surgical centers to get things out of the hospital and away from the single pricing system. And so what they came up with was a global budgeting system where they say your prices can go up and down. You're going to have single pricing. And you can say that to a hospital system. Your prices can go up, your prices can go down, even within the context of a single year. It'll only be one price for all, Medicare, Medicaid, and employers. But that price will be adjusted so that you make a budget. And that budget will grow every year because we still have inflation, but not as fast as the rest of the economy as it had been for many years, but at a slower rate. At
Mhm.
economic growth minus 1%, you could pick a number. that again is reasonable. But over time, this will gradually begin to build, bring prices in the United States down towards more international levels for other advanced industrial countries and reduce the share of our economy that is actually going towards healthcare spending, which let's not
Goodness.
forget, healthcare spending is in many ways a benefit, whether you're on Medicare, Medicaid, or on an employer-based plan. And we do it that way in a very complicated way, but in essence, it's a thing that you buy through your wages or through your historic wages if you are now on a Medicare government program that you paid in through taxes all of your life. And so by saying we're going to uh, bring that down over time, we're actually creating a mechanism for transferring more of the money out of healthcare without damaging healthcare into people's paychecks, into the tax system, so that we can do other things like building housing or mass transportation or providing, better food stamps for the poor, better, supplemental
Mhm.
nutrition assistance for the poor. It gives us the wherewithal to do other things. Not to mention, on the employer side, it gives them the ability to say, we're not going to put $2 of your $5 increase into healthcare
Yeah.
this year. We're only going to put $1 into healthcare, and that gives another dollar that we can put into your paycheck for you to decide how you're going to spend. So the global
Right.
budget gives what I like to call an off ramp to the constantly rising price that rises at the same rate as the rest of the economy, which in a sense of thinking of it in inflationary terms is, twice the inflation rate. Okay. And I don't want to go through all the math here because it can get confusing. But by doing that, what you're doing is you're creating an off ramp for providers, hospital systems, physician offices, and the global budget also has the benefit of saying, if I know I'm going to make X amount of dollars this year to get my global budget, no matter how many heart operations I do, no matter how many, liver transplants I do, no matter how many colonoscopies and knee replacements I do, I'm going to make that amount of money. I now have an incentive to say, I would be better off if I actually helped people not uh, put on so much weight and so that they're going to need knee operations when they're 55 years old. Or I have an
Mhm.
incentive to send people out into the neighborhood to make sure that they're, visit them in their homes, take their blood pressure, take their, blood sugar measurements and say, wow, you're on the verge of having, you have high blood pressure that puts you at risk of a heart attack, or you have elevated blood sugar that puts you at risk of diabetes. Why don't we take these take these medications? Why don't you get into this, diabetes prevention program? And you work with the population as a whole. And what you've done is that you're using your resources to create better health, which in the end drives down the amount of actual sick care you need to provide
Right.
over time. And what it does is it allows you to become a true healthcare system rather than a fee for service we pay for every episode of sick care. And that's,
Mhm.
I think, a
Mhm.
real benefit of the global budget approach.
Yeah, and I think actually some of the, recent evaluations of the Maryland system have found that there have been increases in quality, fewer hospital readmissions, that kind of thing, other measures of quality to show that the global budget system can work in that way to improve quality of care and incentivize preventive services. Okay,
Right.
so here's the hard part, and
Okay.
that is how to pay for all of this and to get it done in a supremely polarized Congress. Now, if you hear single price system, and you've said that the prices are gonna have to be higher than what Medicare and Medicaid paid now because the higher rates paid by private insurance companies, basically the argument is that they basically do subsidize Medicare and Medicaid, and then if you have a cap on out-of-pocket, that might mean someone else is gonna have to pay for the expenses above the cap. So we've got that, and then we've also got the politics of the reform package. Given that people have tried really for decades to pass cost control measures, right? And unfortunately, I think when people hear single pricing and global budget, their knee-jerk response in some quarters is rationing, desk panels. It's really hard to persuade Americans to consume less healthcare. So what are your answers for this? How are we gonna pay for it, and how are you going to persuade Americans that this is not just the right thing to do, but it is politically feasible, finally, after 40 years of debating healthcare reform?
Yeah, so let's deal with the financial question first, which is raising taxes. I'm not afraid of saying, yes, we're going to raise taxes. But when you've just given this huge tax break to corporations through the one big beautiful bill, extending those, which is going to cost the Treasury $4 trillion over the next decade. Okay. And if at the same time you're also giving employers and we major corporations are going to, if we go to single pricing, are going to be getting a huge reduction in their outlays for health insurance, okay? Because we're shifting it to the public sector. I think you've laid the groundwork in a fairly simple way to explain we're not raising employers' taxes. We're just recapturing the money that they're already putting into the system in a fairer way. And the question becomes how to do that. Okay. We're not even talking about recapturing the money they're getting in tax breaks from the two Trump administrations.
Uh-huh.
We're talking about recapturing the money they're already spending on healthcare. And so the way to do that, you can do it in a variety of ways. You can do it in a mix of ways. I put in the article a very simple and clean way to understand it. Right now, when you go to work, you have, if you look at your pay stub from your paycheck closely, a 1.45% Medicare payroll tax. Your employer pays the same 1.45%. That's a 1-to-1 match. Okay? Well, what did I say employers currently pay compared to employees currently? They pay 3-to-1. They pay
Uh-huh.
75% and you pay 25% of your plan. So why don't we treat the Medicare tax the same way? We could have the Medicare tax be your same 1.45%, but instead of them paying 1.45%, they would pay the equivalent of 3 percentage points higher. I'm just rounding up slightly. Okay,
Uh-huh.
1.45 and 1.45 is 2.9. You're adding 2.9% or 3% to that 1.5. And my back of the envelope estimate is that well, by definition, it raises the same amount of money that the Medicare tax doubles the amount of money that the Medicare tax raises. And I did some back of the envelope calculations. That's about the reduction that employers would see as a class. But now let's not forget how that tax will be distributed. Again, I go back to what I said earlier. It's going to be, if you make $200,000 a year, your 2.9% increase on the employer side, and your employees are making a lot of money, then that's going to cost you more. If you're only making 30, 40, $50,000 a year, that costs you a lot less. So putting this on the tax side is going to say, we're not going to penalize you for having the sick workers. We're going to penalize you for having the best paid workers. And it really changes the entire structure of the system and makes it fairer in many different ways, not to mention not putting the burden on the sick and on the people who are hiring people who happen to be sick simply because they are older and maybe have been doing backbreaking labor or working class kinds of jobs their entire lives. Now there are other ways to add to this. You don't have to do it all on the payroll tax. We could begin taxing unhealthy behaviors. I mean, Robert F. Kennedy, forget about all the stuff he does on vaccines. He said some good things around the whole issue of processed foods and sugar-laden foods and, healthy diets. Well, we can tax those kinds of things that are contributing to ill health. We can tax pollution. We have huge asthma problems in this country that have been growing. It's because of small particulate matter in our increasingly crowded urban areas. We're a growing population when everybody is driving gas guzzling cars. We have small particulate matter that makes people sicker. It gives more asthma, more lung cancer, those kinds of things. uh, we can tax that as well. So there are other ways of reducing the payroll tax burden, doing a mix of things. But again, I'm not scared of running away from this. The whole idea of, oh, you're going to raise taxes. I said, well, yeah, of course, because we're lowering your other costs and we are putting the tax burden where it belongs, not where it currently is. And so
Mhm.
I think that there are strong arguments, I think, for overcoming the tax question. The second question you raised was, well, people are going to say, I don't know, reframe it. It's like, what is the political opposition to this? You are taking away what we have?
Mhm.
No, not really.
Rationing, right? It's
What?
always rationing. I mean, that's always the
Rationing,
argument that
right.
comes up,
So we're,
rationing,
ta- we're,
right?
we're going to ration care. Well, right now, don't ration care. We ration care in a different way. We ration care through price. We ration care through when somebody says, "Oh my God, you mean my copay on that is going to be $10,000 because it's $100,000 cancer drug, and I've got to pay by my plan 10% of the cost of whatever drug I buy." And some plans are like that. Then what does that person do? They say, "I think I'll take. It's too late. I'm not going to do the treatment. I'm not going to fight to stay alive, or whatever. I'm not going to pay that." That's how we ration now. So to say we don't have
Right.
rationing now is just a misnomer. We just impose it directly on the sick by making them go into a financial crisis, and that's all about the rising medical debt problem that we talked about earlier. And so I think moving to a system where we say to the providers as a group, the hospitals and the doctors, you take care of all of these people, and we're going to put you on a gradually declining budget, declining in terms of projected growth. Let's not forget, which is always, if you read every CBO report, if you read every Center for Medicare and Medicaid Services report, the growth in healthcare spending is always projected to be at about the same rate, if not faster, than the overall economy. Now, some of that is due to rising, aging of the population. Some of it is due to technology. But the general reason why that growth stays where it is because hospitals and doctors over time get price increases that enable them to maintain growth at economic growth. And what we're
Mhm.
saying to them is, we're going to give you the budget. We want you to make people healthier, and we're going to give you a long glide path. So today, if over 10 years or 15 years, instead of being 18% of the economy, you're going to be 16.5% of the economy or something or other. And, demographics will help us as my generation departs the scene. It's inevitable, but the baby boom generation, I'm right in the heart of it, right? I was born in 1950. So, we don't live, nobody lives forever. So it'll be helped somewhat by demographics if you look another 15, 20 years down the road. And so you're creating a system that takes advantage of the demographic change, that also puts them on a different incentive structure for delivering better health, so that reduction, I used the word earlier, I'll use it again. It's a glide path away from the constantly increasing prices and increasing share of the economy that healthcare has taken over really the last several generations. And it's really
Mhm.
time to bring that process to a halt in a positive way.
Well, thank you, Meryl, for your insights. Really appreciated having the chance to speak with you. I'm Ann Kim, a senior editor at Washington Monthly, and I was speaking with Merrill Goozner, former editor of Modern Healthcare and the author of the newsletter Goose News here on Substack. He also wrote a provocative and must-read article for the Monthly. Thank you, Meryl. Talk to you
Well,
later.
thanks for having me on, Ann.
Take care.